Okay, so Assalamu alaikum, everybody, and welcome to yet another Apne webinar. My name is Dr. Ahmed Bernie, and I'm of the Association of Pakistani Physicians of Northern Europe. I am much indebted to our mental health task force led by Dr. Hassan Javed, Shahid Latif, and many others who have taken the time out today to present yet another fantastic webinar to all of us. I'm looking forward to it. My colleague and moderator for today is Dr. Sobia Rafi. Much indebted to our mental health task force led by Dr. Hassan Javed, Shahid Latif. So I'll start again. My colleague today is moderating is Dr. Sobia Rafi. She is a consultant child and adolescent psychiatrist, and she's based in the Black Country Trust, Walsall, United Kingdom. She's also the medical lead for Eating Disorders Crisis Services in CAMHS. She's a member of the Royal College of Psychiatrists UK and has a distinguished education career, graduating from the Aga Khan University in 2001, and has been awarded the Alexander Mezzi Award by the Royal College of Psychiatrists in 2011. I'm thankful to Dr. Sobia Rafi for her time today to be the moderator. Over to you, Sobia.
Assalamu alaikum, and thank you so much, Dr. Ahmed Bernie, for the generous introduction. So I would like to thank everybody for joining us for this third webinar, which has been arranged by the Mental Health Task Force at APNE. And before we begin, just wanted to let you know again that the meeting will be recorded. And if you're joining us on Zoom or Facebook Live, please put your questions and put your comments, and we'll try our best to put all of them to our speaker at the end of his presentation. So just to introduce the topic today, so we are facing possibly one of the biggest pandemics and biggest health crisis for generations, and it has had a profound effect globally on everyone. So be it elderly or children or adults. So it's not just the medical sequelae of the COVID-19 that we are all worried about and are affected by, but it is the socio-economic impact because of the isolation, the social restriction, and also the economic shutdown, which has affected everyone. So we all know the schools have shut down, the leisure activities have been canceled, and the social support has just fallen away. So what has happened is that the parents have had to step in as not only parents, but as educators and also as entertainers, whilst they've been managing their own anxieties, their own mental well-being, and working from home. And I think we have all experienced that. So all these anxieties and worries around the socio-economic aspect have led to increase in distress, increase in mental health problems, and crisis. So that leads to the topic for today, which is managing the mental health of children and adolescents during the pandemic. And our speaker for today is Dr. Shahid Ahmed, and he will be introduced by the chair for our webinar today, and that's Dr. Asfa Zainab. And I have the honor of introducing Dr. Asfa. So Dr. Asfa is a graduate of Quaid-e-Azam Medical College, Bahawalpur from Pakistan, and she's a consultant child and adolescent psychiatrist. She works in Surrey and Borders NHS Trust. Her special interests are in neurodevelopmental disorders, ASD, ADHD, and also in anxiety and OCD in children and adolescents. So she does other quite significant work for the trust as well. She's the BAME Network Trust member and also the founding member for the BPPA. So I would like to welcome our speaker and our chair, and over to you, Dr. Asfa.
Thank you, Sobia, and good evening to everybody. As Sobia has just briefly touched upon the importance of this seminar, so increasing the mental health difficulties and the psychiatric morbidities is just not specific for COVID, but any disease outbreak or pandemic or even natural disaster will lead into this. But this time it is like a worldwide situation and multi-layered effects, as she's touched upon. And we are looking into this from the side of the children's world because it is having impact of the child and the family around the child, and then the environmental community kind of aspect. And more importantly, we're going to look into how to manage this whole crisis, which I'm sure our presenter today is going to talk a little bit more in detail. So I have the pleasure of introducing Dr. Shahid Ahmed, who is a senior CAMS consultant, and he's a clinical lead as well in the Children's Mental Health Service in Burnley General Hospital, and he's a fellow of Royal College of Psychiatrists, and he has got a special interest in psychological trauma, PTSD, depression, ADHD, and autistic spectrum disorder. So over to you, Dr. Shahid, please.
Thank you, Dr. Asif, for your kind introduction, and thanks to Dr. Amar Birnie for giving me this opportunity on APNI's platform to present this webinar regarding psychological impact of COVID-19 on children and adolescents. I will be mostly focusing on the management of these disorders. We are living in historical times. There is a global uncertainty. It is well known that psychological trauma can touch the life of everybody. There is a pandemic of fear, anxiety, grief, and depression parallel to the COVID pandemic. It's an evolving story. Clinical picture keep on changing. We are not sure about the long-term impact. One thing which is sure is the COVID pandemic is going to produce significant social and economic crisis, which will have a long-term impact on children's not only psychological health, but also physical health. There are close links between parents and children's mental health, and family dysfunction is one of the biggest stress factors in children's life. The second is bullying. Bullying is also a very stressful factor. Previously, it was thought that children are more resilient, but that concept has been proven wrong. So nowadays, it is well known that psychological trauma or abuse during critical periods of early development, and if child lives in a negative emotional state for some time, can change to physical structure lead to the physical structure of the brain. It's just like suffering a head injury, and it could have a long-lasting effect on child's future development. Children are different from adults because same stress in different age group children present in a different way. By the way, the legal definition of child is child up to 18 years of age, and then it's adult. There is no legal definition of adolescence. So if I say children, you can understand it is up to 18. I would like to describe about sleeper effect of the trauma, because sometimes there is a time lag because the onset of the trauma and the manifestation of the symptoms. I'll just give you an example that if 5-year-old girl gets involved in a road traffic accident and gets facial scarring, she will not respond to that facial scarring at that age group. It will be that when she is going into adolescent years, when issues of identity formation and issues of attractiveness become much more prominent, she will react to that scarring at that time and actually might become anxious or depressed, or might get some other trauma symptoms. So in a way, the trauma occurred age 5, but it was sleeping for 10 years. But at the time of adolescence, when the young girl was able to appraise the cosmetic disfigurement, she reacted to that. The take-home message is that some of the people in the even adult life who are presenting with psychological disorders, one need to look back into their early childhood, because they might have suffered traumas which still casting shadow on their lives. I find child psychiatry as a fascinating field. I've been a consultant for the last 20 years, but I still enjoy it. Each day brings a sort of new challenge because each child and each family is different. And there are 2 skills you need to have in child psychiatry. One is your observational skills, and then you're able to interpret the behavior of the children, because the children usually do not describe their emotions, they act out their emotions. So they present in a different ways, and you should be able to understand, they make sense of their behavior and get at the bottom of their sort of a distress. And as I said, each day we see new patients. I have never seen a patient during my clinical time who has come to my clinic in a 3-piece suit. And it happened about 3 months ago before this lockdown. I saw a 12-year-old boy who came in a 3-piece black suit with a white shirt, black tie, nicely polished shoes, black shoes, nicely done hair. He was in very good physical health. So he came in with confidence and he shook his hand to me and said, James Bond. Well, I said, well, James, good morning to you. How are you this morning? He said, oh, Dr. Ahmed, I'm all right. I said, James, are you on a mission today? He said, yes, Dr. Ahmed, I'm on a mission. I said, what is your mission today? He said, you know, I brought my parents and they need some help. I said, what's wrong with your parents? He said, you know, they shout at me, they yell at me. They always critical whatever I do. They frequently take away my phone. And my main difficulty is every night they fight with each other and that disturbs my sleep. So I think you need to sort them out. So I said, James, you're in the right place. And that's my job. My job is to sort out parents and we'll do it for you. So anyhow, I mean, that I interpreted in a way that this child was so anxious to come to see a child psychiatrist because there's still a stigma. So he was very anxious about it, but he tried to control his anxiety by taking the persona of a James Bond, because James Bond was very strong. He's very good in killing villains. He's always on the task. So that persona helped him to come to the clinic and able to describe his difficulties. So it's not uncommon a number of children can take the role of Superman and Spider-Man. And I remember another patient of mine who believed that he's a Superman and he can fly. And one day actually jumped out of his window. And fortunately, he fell on a shed and didn't injure himself. So I think this is how the children present their predicament and you're able to really interpret their distress. Other thing is, another patient I would like to describe to you is that this is a ADHD child with the age 12 who came to see me and I'm with his parents and I'm going to put him on medication. And he brought a A4 paper with him and he's written there, my name is Dr. S. Ahmed, but he said, Dr. Ahmed, your name is not Dr. Ahmed, your name is Dr. A. Mad. And so I basically interpreted it, he was asking me, is he mad? That's why he has been asked to come to a see child psychiatrist. And is he mad that I am going to prescribe his medication? So I have to really explain to him that ADHD is not a mental disorder. It's a developmental disorder. And the medication we are going to give it to you is not a tranquilizer. It will help you to concentrate at school and help you with your education and you can achieve your full potential. And even your eye-hand coordination could get better and so would be your handwriting. So he was quite happy with that. So really that was a very creative way by that child to ask me a question that so this is it, what I'm making. Children are very, very creative. So you need to be yourself able to understand their actions, what they actually mean by that. Other thing is that, as I said earlier, that different age group children present with different symptoms. So a child suffering abuse at age 5 will present with the following symptoms. And age 15 will present with the light anxiety, depression, deliberate self-harm behavior, running away from home, truancy, school refusal, drug abuse, antisocial behavior. So this is the difference. And even if you want to assess and treat these children, you have to use different therapeutic approaches. The one thing which is quite common in this COVID pandemic theme, which is really coming across, that is the theme of loss and grief. And their losses are multiple. Obviously, as I say, personal freedom, friends, school, routines, teachers, loss of education are very significant. It would have a long-lasting impact. Loss of sporting activities, physical space is limited, loss of key attachment figures. They can't visit their grandparents, some parents are separated. So obviously loss with the separated parent. And then the real loss or real grief associated with death of one of the close key attachment figures, might be parent, might be grandparent, might be uncle. And obviously the loss of other social events like birthday parties. There are further losses for the children who have pre-existing psychological problems because they're unable to access psychological support. There is a loss of face-to-face services, and telephone and online therapy, though useful, some of the children find it stressful, and even some of the professionals find it stressful. Other feelings associated with the COVID pandemic, which is quite paramount in not only in children, but I'm pretty sure in adults and in adults also, which is isolation, entrapment, loneliness, fear of death, which is a real fear of death. guilt feelings, excessive anger, stroke, irritability, and feelings of hopelessness or being out of control. People feel that life is not, their life is out of control. Or some people feel life has stand still, it's not moving. Now I'll describe a group of vulnerable children who I think will be impacted more by the COVID problems. And these are the children with the pre-existing psychological problems of like anxiety, depression, ADHD, autism spectrum disorders, and OCD. Particularly, lockdown is particularly difficult for autism spectrum disorders because they like routine, they like sort of a they like the rituals, and they have difficulty in accepting change, but everything has changed for them. And so is ADHD children because they like a lot of space. They need to run around to burn out their excessive energy. And now they're asked to stay in houses, so they're causing a lot of difficulty for the parents and their siblings. And obviously depression, self-isolation leading to loneliness, no circle of friends, no activities. So some of our depressed patients are getting more depressed. Other vulnerable children, as you know, are the chronic physical disorders. There's a close relationship between chronic physical disorders and psychological disorders. Children with chronic physical disorder anyway has a higher incidence of child psychiatric disorders, particularly if it is affecting the CNS, any central nervous system disorder in children, 5 times the risk of developing child psychiatric problems. So we're having difficulty with diabetic children. They're not really complying with their medication, and their sort of diabetic control is up and down, and they're going into hypo and hyperglycemia, causing a lot of headaches for the parents and even for the pediatricians. Number of children, their eczema, and in some cases even asthma has exacerbated by the associated stress. I know one child who has chronic liver disorders and ADHD. He was up for a liver scan. He refused to go because he's fearful that he will catch COVID in the hospital. So he's not really going for that. And in some patients with epilepsy, the poor compliance has become a problem, and some of them having a pseudo-epileptic attacks because of excessive anxiety, but it's very difficult to differentiate what is true, what is the difference between the true and pseudo-epilepsy. Then there is a other group of vulnerable children like living in residential home who have lost their own homes and lost their key attachment figures, children in foster placements, refugee and migrant children, parents with mental illness. Now, parents with mental illness is a significant risk factor for children. If any of the parents have depression, it means that adolescents or even children are more likely to get depression, and their depression will be early onset and treatment will be difficult, and sometimes it's become chronic. But obviously you have other effects of mentally ill parents because they might not be able to look after their children well, they might not be able to do household chores, or they might involve children in their own symptoms, which can be quite troublesome. Now, there are a number of parents with physical disorders, some with Parkinson's, other CNS disorders, and some of the adolescents have to act as a carer for them. We call them as young carers. And parents with drug abuse problem, again, there's a big risk factor for particularly in the lockdown situation. And then there's a domestic violence. There is a clear evidence that incidence of violence has gone 20% up, and basically mothers are at the facing the very difficult task to cope with it. Poverty and children from broken homes and family dysfunction are also very vulnerable. Yeah, as I said earlier, that children and adolescents present with different psychological problems. So in younger children, you will see following symptoms like excessive temper tantrums, sleep difficulties, changes in appetite, fear of monsters. They believe that there are monsters around who is killing others. Emotional regression is quite a common symptom. Children start behaving like a much younger child, like a baby, even changing their language. Bedwetting, swallowing is other. Sometimes separation anxiety or clingy behavior. Younger children becoming very clingy with their parents or wanting to sleep in the parental bed. That's an issue. Going to the psychological problem, adolescents. These are the main sort of symptoms we are observing at the moment, like fear, death of dying, fear of unknown, anxiety, stroke, panic attacks, changes in appetite and sleep pattern. It could be both ways. Either they will lose their appetite or they will eat more as a comfort eating. Or some of them actually are sleeping more, and others who have onset insomnia. Obsessional symptoms, post-traumatic stress disorder, if particularly in some of the children, episodes of low mood and depression, thoughts of self-harm and repeated self-harm. Wrist cutting has become more prominent during the COVID task, and we actually expecting after the lockdown situation, we will get increasing referrals of children who are basically repeated self-harm behavior. And some of these adolescents have made groups on the internet, and they're doing it as a group activity. They fix a time every day, at what time they're going to self-harm, and then get interconnected on the internet and start cutting themselves. Again, some of the children present with running away, like adolescents running away. Particularly 1 or 2 girls have ran away from home, and even they spend overnight with some strangers because they're having some of them have ADHD, so a lot of disinhibition. Risky behaviors have gone up: drink abuse, irritability and acting out behaviors, agitation. Some of the adolescents, actually their arousal level goes very high, and some of them even develop paranoid thoughts. They believe that people look at them, they become reluctant to go out. Some of them, they are being stalked, and even some of them start having hallucinations, but these are pseudo hallucinations, they're not really true. They started hearing voices. Other problem which we're observing is that because of lockdown, adolescents are spending a lot of time on the internet. And some of the girls actually putting them at risk of sexual exploitation, and there have been few incidents in which police has been involved, and we are aware of that. Internet addiction, I think, will become a problem after the lockdown situation. American has put DSM-5 has put internet addiction into the addictions pattern, because if you stop internet, children do start having physical side effects of that, like any drug withdrawal. This is basically the paradox of COVID pandemic, because currently the most suffering is in the elderly, but it is possible that young people will have psychological suffering, which will last much longer period of time. Grief reaction: if one of the key attachment figure, maybe your parent or grandparent or a close uncle, dies because of the COVID, then there is a problem of grief reaction. And grief reaction is severe because you have been unable to visit the ill person in the hospital, and even after they have been either buried or cremated. So you have no chance of saying goodbye to that. And obviously you don't have family support around you to help you this grief period. So actually grief reaction is going to more severe. And it's characterized by shock and denial. Denial is sometimes children behaving in a way that nothing has happened, and they carry on their life as a normal way. Sometimes they search for the deceased person, or they feel the presence of the deceased person. They can hear the voice of the deceased person. Some younger children have guilt feelings, and they believe that they were naughty and they didn't behave well, their grandparents, that's what they died. Some of them express wish to join the deceased person. They should be considered as a suicidal thought and should be taken seriously, because we know few children who try to sort of harm himself in a grief situation with a wish to join the deceased person. Anger towards a deceased person or anger towards self is common. Again, anxiety, depression could emerge. Sleeper effect, as I mentioned earlier. Now, concept of death does not develop in children before the age of 6. Younger children believe that people who die go to heaven for having holidays, and then they come back. So younger children might not react to the present with grief reaction because of the key attachment figure, because as I said, they don't have concept of death and they believe they might come back. But when they will develop the concept of death, which is around the age of 6, then they will realize that the separation is permanent, the deceased person is not going to come back. So then they will into grief reaction. So there will be a time lag between the sort of death of the key attachment figure. And so within a year or two, we might see a number of kids who are going into 6, 7, 8 years of age presenting with the grief reaction. Now, going to the management of psychological complications in the COVID pandemic, these are a few principles. Engagement is the key thing. Engagement is the key therapeutic intervention which you need to make with children and their families. And if you can do it, 50% job is done. But some of these families are very difficult to engage, or sometimes you have to really work with the variable engagement. And so then psychoeducation, either you need to psychoeducate the parents so they can psychoeducate their children. And obviously you need to use the language which the younger children could understand and different language for the adolescents. You need to tell them that COVID-19 fortunately carries low risk for children and adolescents as compared to elderly population. They need to know, okay, why there is a lockdown, why there is a social distancing. Some children are getting very distressed because they're not able to having hugs from their key attachment figures. Even my own son, he was very upset. He's an F2 trainee at the moment, and obviously he was not able to come home because in a hospital. But when the lockdown lifted and he got his test done, he came to see me. And first thing is that I need to have a hug because I'm really missing it. So I think hugs were very important for these children. Young people are especially, the other take-home message is that the children are very sensitive to our own or parents' body language. And then they are very sensitive to what we see and what the tone of voice we use, what posture it is, and what our facial expression. So we need to be careful while talking to younger children. If you're trying to reassure them and you're yourself feeling very anxious about it, they will immediately perceive your anxiety. So I think we need to be careful of that. Other sort of management tips like active listening to children, giving them a specific time if they want to discuss you with their anxieties and worries. Limit exposure to the news and multimedia and news has the potential to cause a lot of trauma and stress for the children and adolescents, even for the adult population, because horror stories going on the news and news for 24 hours a day, giving all sort of figures is very, very traumatic. And I have difficulty with my own missus to try to restrict her viewing the news. So I think it's very important to limit the exposure of news to the children and adolescents. Structure the day. Family need to might establish a timetable and their routines, and homework or schoolwork should be part of the timetable. Also, parents need to limit time. The children couldn't use internet because, as I mentioned, the problem of internet use, and also they can be exploited on the internet. If there are some issues in the family, they could have a family meeting and try to discuss those differences. And I think parents need to be more generous in expressing love for their children during this COVID pandemic. There are pleasurable activities which children could do at home and spend more time with pets. Some children have very good attachment with pets, and actually spending time with pets could be very rewarding. Looking after their pets could be rewarding. I have seen a number of children, like a 10-year-old boy, who became depressed because his dog died because there's such a close attachment with him. His dog's name was Oscar. And while we were treating him, I suggested to his parents that they buy him a new dog. And the new dog's name was Oscar too. And next time I saw him, he was more depressed. I said, what's the matter? Why are you more depressed? I bought you a new dog. He said, Dr. Ahmad, this Oscar 2 is very naughty. He jumps up and down. He destroys my room. He's all the time jumping up and down. And my previous dog was very cuddly and very nice, and I really enjoyed his company. So I told him, I said, oh, that dog was very old, but this dog is very young. He's like you. You are young and he's very young. So he knows that you are depressed, and that's why he jumps up and down to make you happy. So you need to make a relationship with him. So he started taking his dog out for walks and started playing games with him. And next time he came, his depression lifted. So I think the relationship with pets is very, very important. Pets are even being used and doing therapy with some nonverbal children. And we actually sometimes advise parents, if the child don't have any pet, buy a pet for them and let them develop some relationship with them. There are other pleasurable activities like can be done at home, like drawing, painting, coloring books, craft work, photography, but you need to provide them materials for the crayons and other craft work material for the children. Sewing and knitting for the girls or for the boys if they like it, learning new skills like learning to cook, like learning to bake, spending time with the nature in the garden if they have a garden. and maybe plant something. So these are sort of activities which you can do during pandemic. Staying connected, socialization is the key need for human beings. Actually, is the higher need even than the food. People will die if they're not really socially connected. So we strongly encourage the children and families and their parents to stay connected with their siblings who have moved away, with their grandparents who are living away, even the parents who are separated, friends, school, even teachers, or reconnect with the old friends. That is also a very good strategy to use. Then they can make a kindness project at home, i.e. doing some favor to the family members, teach somebody new skills like your younger siblings, make a gift for somebody, write a letter to your grandparents, help parents in household chores, and be nice to your younger siblings. So you can add a number of things while encouraging child to make a kindness project. Other thing which is a quite useful strategy is that is worry postponement. Parents need to set aside some time every day for a specific purpose of worrying. Maybe let's say between 7 p.m. and 7:15 p.m. If an anxious thought comes to the child during the time, child need to check whether he can deal with it. If he can deal with it, he need to take an action. If he can't deal with it, then he should tell himself that postpone it till 7 p.m. And some parents then need to remind the child at 7 p.m. that their worry time has started, so they should start worrying. And some children, you can help them and encourage them that if they are worried during at their worry time, they need to write down their worries. So that's a useful strategy. Other thing which we can use at home is what is called as a happy box. Making a box, maybe shoe box, decoration, putting some nice paper on it, making as a nice labeling as a happy box. And then you can encourage children, adolescents to put some nice things in that box, like some old birthday cards or some award certificates they received from school, maybe some old photos they like, badges, letters they have received, some toys, some cuddly toys, or some dolls, small dolls, or gifts they have received. So they put them in this box and label is a happy box. So these are quite good sort of anchoring your sort of happy memories to you. So we encourage children to sort of go through their happy box during the before sleep time. So this helps them to get distracted from the negative thoughts and anchor into the old memories which were very rewarding for them. So this is a very interesting tool. Every child could make a happy box at home with what sort of things they like, and they can put it in and then look at it during the night time before going to sleep. Then there are anxiety management skills, which has got to be taught in a short space of time, like mindfulness, relaxation techniques, martial arts. Martial arts are very good in dealing with anxiety, depression, and even patient who depressed. You can get martial art lessons on YouTube. There are some programs are available on the YouTube. Even yoga or other sort of could be quite useful in dealing with the symptoms of anxiety and depression. Maria Kovic is a child psychiatrist who did a lot of research on depression in adolescents, because adolescents really do not respond well to antidepressants. The effect size is very limited. Therefore, she was interested to what other measures could be used to help children with depression and even anxiety. So what she's come up with is learning to play a musical instrument, i.e. learning to play guitar. And the research has shown that if you start learning to play a musical instrument, it leads to growth of the brain. And also deal with the anxiety and depression symptoms. So encouraging the children to play musical, even if they have second-hand guitar, there are some free guitar lessons on the YouTube where they can do. Listening to music is not that useful. It's learning to play a musical instrument is very useful. Crosswords and puzzle, we encourage, she recommended doing crosswords and puzzle, because when you are doing crosswords and puzzles, it's the back part of your brain which is more activated, and blood actually flows towards the back part of the brain, and the parts of the brain like sort of a hippocampal area and the frontal cortex, which are more involved in anxious and depressive thoughts, they get calmed down and blood flow goes towards the area where your problem solving skills are. So they get distracted. So we encourage them to do crosswords and puzzles. Reading favorite books and watching some comedy films could be also useful mood hygiene measures. In addition, some children have difficulty with sleep difficulties, so we also advise them sleep hygiene measures. A glass of milk with the honey in it or a toast with the butter and marmalade at bedtime could be a very useful hypnotic because it contains a lot of tryptophan. We try to discourage children not to use their phone or multimedia an hour before going to sleep. So I think these sort of things could be also useful for the children who are having sleep difficulties. If symptoms become sort of more significant and there is a functional impairments, and obviously referral to the child psychology or our services might be required. In our department, we have these psychological therapies available for the children. Obviously, for the younger children, we will go in the context of play therapy or art therapy. And for adolescents, we will go with the CBT or trauma-focused therapy, family therapy, and group therapy. Now, family therapy is the key element because all the feelings and issues of grief I describe is not that the child who has been referred is presenting with that. One would expect all family members, including parents, including other siblings, will be going through the similar sort of grief feelings and feelings of loss. So family therapy is the best medium to engage the families and try to work with them. Currently, we are unable to do any really group therapy, but family therapy is the key interventions, but obviously play therapy and art therapy, if we can do on online or going on to the Microsoft Teams to do it. Family therapy, you can also do on Microsoft Teams. Last one is the spiritualities. The having strong religious beliefs is very protective. And I just give you an example of how having strong spiritual beliefs are protective. This is nothing to do with the COVID pandemic. I was asked to see a young man about 11 years old who had 3 failed renal transplants. He has a kidney failure and 3 renal transplants failed, which is a very significant trauma associated with that. So he was up for the 4th renal transplant, and nephrologist asked me to have a look at him because he was living with a single mother and causing a lot of difficulties. So he came to see me. As soon as he entered my room, mother said, Dr. Ahmed, he is going to die. So I don't know why Mr. Johnson asked him to have a look at him, because he is going to die very soon. His 3 renal transplant has failed. His kidney is not working. There's no point in having any therapy or anything like that. The boy said, Mom, you're wrong. I am going to be all right. My 4th renal transplant is going to succeed. I said, well, this is a very resilient boy. Mom is saying he is going to die and he is saying he is going to live. So I asked him, I said, John, why you say you're going to live? Because your renal 3 have failed. He said, Dr. Ahmed, I go to church and Jesus tells me that I am going to be okay for 4th renal transplant. I said, but how you know that Jesus tells you? Can you hear Jesus? He said, yes, he can hear Jesus in the church telling him that he is going to be all right. And sometimes he can see Jesus in the trust telling him that he is going to be okay. So how you explain it? Basically, mother, when she said this boy is going to die, she was already what we call as anticipatory grief. She has already assumed that his child is going to die. This is very Jesus, and he was actually having a fantasy or imagination in the sense of talking to Jesus, having images of seeing Jesus in the church, which was very protective for him. So I think one shouldn't hesitate to explore the spiritual aspect of the treatment, because strong religious belief could be quite protective. Antidepressants are available like fluoxetine, sertraline, and citalopram. We use fluoxetine for depression in children and sertraline for children who are severe OCD, which are not responded to therapeutic interventions. I am not very fond of antidepressants. We try our best to treat with the psychological therapies. Fluoxetine in depression is recommended, but effect size is limited, and so is sertraline. But having said that, some children do benefit from antidepressants, but if you're going to give them antidepressant, you need to tell them that it is going to take 8 to 12 weeks before they start feeling better, though an anxiolytic effect starts quite early on. One word of caution is COVID is considered as a multi-system disorder, and there are reports that it can change the pharmacokinetics of the psychotropic drugs. So fluoxetine are already prone to give sort of a bleeding in the stomach. So one should be very, very careful and check their pharmacy to whether or not it's safe to prescribe psychotropic drugs during COVID pandemic. Few principles of the management: start early, risk assessment and management should be ongoing, target multiple risk factors, always treat in the family context, treatment sequence over time, minimize the effects of negative life events, evidence-based interventions, keep going very slow, very important. Some vulnerable children and families, if you make intensive intervention, they decompensate and go worse. So for these families, you have to keep your interventions low and going very slow. Always try to instill hope. This is all doctors, wherever setting they are, because installation of hope is protective for your patients, and you need to give them a genuine hope. And when they are in the time of stress or distress, they will always remember that Dr. Ahmed or Dr. Bernie told him that he is going to get better with the treatment and he should be patient. So installation of hope is the key intervention one can with your patients. Again, emphasis on the healthy diet. There are some information that people lacking in vitamin D are more prone to COVID infections and their symptoms are more severe. And there are also information about people having a balanced diet and people like zinc and selenium trying to be more important for their immune responses. So encouraging a balanced diet, fruits and vegetables. Iron is very closely associated with depression. Low levels of iron cause depression, and even low levels of vitamin D could lead to depression. So need to check out the iron. Iron is the element of happiness. Iron is closely involved in the neuronal metabolism and even transmission of the impulses in the neurons, so it should be checked. Omega-3 fish oils, all doctors should try it. They're good for your brain and your memory. Towards the end, I would like to mention a few of the positive aspects of the COVID pandemic. I should thank COVID for that. That one is the sense of togetherness. We are all in together, all over the world. All world is involved. We are not invincible. Even the big powers have been brought onto their knees. Our health is interlinked. It has brought families together, brought neighbors together. Even I can see my neighbors talking to each other more from social distances. They never spoke to each other before. Brought neighbors together, emphasis on the hygiene, focus on the clean environment. It has but one thing is very important. It has highlighted the deeply entrenched health inequalities which exist everywhere. So there is a need for a careful reflection, and the key message is compassion should be at the heart of the healthcare services.
Thank you.
Thank you. This is the end.
Thank you very much, Dr. Shahid, for quite a good summary and just kind of talking about everything in a very concise way. I have picked up quite a few questions, and there are a few themes which I can just try to kind of make it in a one theme. So first thing, as you said, that there are quite a lot of challenges. And in this time of COVID, I think the referrals were quite sort of low because people were scared to come out, and probably they were holding on to the problems, and it's going to lead into a surge of the referrals. On the other hand, we have got quite a limited resources in a way because of the procurement, and people have been sort of on scandalment on other services, personal unwellness or being in quarantine and stuff, and there is a lot of pressure on the services from all aspects. So is there any way how we can suggest any management, and then it will lead to my next question. So if do you want to answer that, or we all can share?
One thing is very clear, okay, there is going to be avalanche of referrals immediately after since the COVID. Even we have seen rapid escalation in the number of referrals. Even today, we did a referral meeting, and previously we were getting 5-6 referrals. Today they shot up to 20. And our service is basically more geared towards dealing with the tier 3 more complex cases in which the primary services have not been able to help. So I think the referral need to go first to the primary services. In our area, there are family welfare services, Action for Child Northwest services are available. Then there are clinical psychology services available for the medium sort of risk cases. And then we take the sort of a higher end of the cases.
Yeah, so probably the answer the way I have.
We have deployed actually the CAMS team members in all the schools in the area. So I think they will be very good resource of linking up with schools and picking up the children who presenting with the difficulty. So that is the structure we will be going through.
Yeah. I think I will add into a little bit more onto that, because of course the consequences of this whole pandemic is going to be very long term. For example, this domestic abuse, which has definitely increased. I just read one of the paper that about 700% increase in April of the domestic violence helpline phone calls. So it is going to bring the challenge to continue. Teleclinics in psychiatry, and there was another question on this one as well. In child psychiatry, it has been tried, and there is going to be more research opportunities. So we are going to talk about how we can use the other resources. So I think this can add into that. And exactly as you said, that schools need to do their job. The primary and secondary care needs to have their plans. And even I think as like any health professional or even any community member, they can do a lot to contribute into these things. And again, one way of management of this crisis or this surge coming up is just to kind of address the more focused services towards the high vulnerability or risky patients, as you have touched upon. So, and these are the different ways of managing. So one question was around the pressure of prescribing the SSRIs and how we can justify if the resources are limited, because medication in child psychiatry is taken as a quick fix. So if maybe Sobia wants to take it just to share the panel, shall I?
Let me just say about the domestic abuse. My understanding is, I've read recent figures, it has gone up by 20%. I don't think somebody has quoted 700% or something, but I think it's basically about 20% increase in domestic violence. But it's a complex issue. To deal with the domestic abuse, obviously safeguarding will get involved, police will get involved, social services will get involved. And obviously we will get involved at some stage when treatment is required. So I think but definitely there's an increase in domestic violence. And I think there will be increase in divorce rate after the COVID.
Yeah, SSRIs and the pressure and the quick fix by the medication?
I think there is a lot of pressure for medication, and the children who can be managed easily with psychological therapies and just work in the community by some of the counselors, because that support is not there. They're coming to the specialist mental health services now. So yes, for sleep medication, there is a lot of pressure for sleep medication, for anxiety and for mood, because children, like Dr. Ahmed said, have become addicted to games. They're not going out, especially neurodevelopmental disorders where autistic children have found it really helpful to be inside for the first month or the second month. Now they are finding it really unpredictable. So their anxiety is increasing a lot. So yes, we have all seen that our prescription rates have gone up, but that's to prevent the crisis, because these children have then resorted to self-harming, running away, and also getting into really risky situations. So you have to weigh the risks and the benefits. So we know hopefully in the next 7 to 8 weeks, hopefully the schools will open and we will have some support coming back. The social support, that network from their friends, from the teachers will be back. But I think sometimes we just have to look at the risks and the benefits, and we end up prescribing to regulate their sleep cycle or to get their anxieties low, so that they will be able to go back to their schools after 6 months. So we have to understand they've never had 6 months off. So the longest in UK that we are off for is 6 weeks. So you can imagine after 6 months, how are they going to get used to waking up early, getting dressed? They're already really anxious about all the things that Dr. Ahmed has talked about, like bullying and all sorts of things which happen on social media. To get them reintegrated back into schools is going to be really difficult. So I think it's just about preempting the crisis and helping when it's needed. Not everybody will get the medication, but yes, we have seen an increase.
I have a different view on medication. There is not little research evidence that medications are effective in reintegrating children to school. Their role in anxiety is also very, very limited. Apart from OCD is the only disorder in which fluoxetine is dependent. As a matter of fact, SSRI not that effective in the adult population. And the difference between placebo effect is very limited, and children are more sort of vulnerable to their side effects, because all antidepressants have neurotoxic properties. But in some cases in which obviously the psychotherapeutic measures don't work, then you can add on low doses of antidepressant and see whether it will work or not. But
Yeah.
I think the
It
most
shouldn't be prescribed under the pressure of services.
and
So
I
that,
am also against giving hypnotics to children, and I am also against giving melatonin to children. Actually, melatonin has been blacklisted by in the East Lancashire area, and some of the professionals have been prescribing them for years, children on melatonin, and it's very clear guidelines. Okay, if you're going to give any hypnotic to any child, you shouldn't give them more 6 weeks because that is not really.
yeah. Can I just correct the domestic violence bit? I said that 700% in April increase in the helpline phone calls. Otherwise, the incidence, especially by the intimate partner, is 20% increase. So if I haven't made myself clear. So there is one more question around the telepsychiatry. So my answer to that is that telepsychiatry, I think it is opening up the more research kind of thing, because it may not be appropriate for every young person. And one of the question was around the typical problem of eating disorder girls, because they were not very much engaging in the telecalls. So to my knowledge, the high risk young people, we never stopped the services. So they were still face-to-face clinics, and with all the cautions, even in the acute phase of COVID infection. So there will be some patients always who are not going to be suitable for telepsychiatry, and Royal College faculty has already started kind of a feedback, and it will definitely lead to more research to see the effectiveness of teleclinics, teleconsultation, and the online therapies as something which we are going to probably develop out of this period.
Is there any other questions from the audience?
Yeah.
These are the questions from the audience on my side of the WhatsApp. Maybe Facebook, if Sobia, you have got any questions?
So Dr. Arif Kadir has asked about what are the observations in young people with eating disorders, and how have they been impacted by the COVID-19 pandemic? So over to you, Dr. Ahmed.
Yeah, eating disorders, we have not really seen any surge in the eating disorder referrals, but some of the severe eating disorder cases have been badly affected. And we have seen the increase in tier 4 referrals. So number of these girls required admission to the hospital. But on the outpatient basis, the moderate sort of eating disorders, we have not seen any, or mild disorder, we have not seen any surge. But obviously, as I said, the severe end of the disorders, there have been more admissions have been requested for the tier 4.
Can I just add, because I work with the eating disorder, so I would agree that we haven't seen a big surge in referral for actual eating disorders, but we have seen a big surge. So that's been like the maximum numbers of referrals coming from April till now of eating difficulties in ASD. So they have been referred as eating disorders from the GP, saying that the weight loss has happened, they're not eating, they're not drinking, and there are some physical sequelae of that as well. But when we have done our assessment, it's very clear that these children have, young girls and boys both, have had social communication interaction difficulties, very clearly autistic, who have not been picked up. But I think it's just that because of the stressor of this lockdown, the unpredictability, the change in the environment, suddenly things have just come to a standstill for them, and they have tried to just control their eating, but it is not the eating disorder psychopathology. So when you have tried to kind of manage their anxiety through trying to do more face-to-face contacts with them or engaging them in family therapy, we have seen that their weight has gone up and they've started to eat better because their anxieties have come down. Like Dr. Asfa said, that eating disorder and crisis services have continued, at least in our camp service as well. So we have continued to see them face to face, of course, wearing our masks and PPE and everything, and giving them masks and things and social distancing. But we have never stopped weighing them. They have come for it. Yes, in between, we have called them or used eClinic or Accurex or some of the safe online platforms. But yes, I think we have continued to see them, because for crisis, face-to-face has never stopped.
There is one question specifically for Dr. Shahid on the panel. That what is your view around the diet for the children during especially the gut inflammation? And if probably, I think it is stress related, I guess.
Well, the main thing about the fat is that basically if there's a gut inflammation, as we know that sugar itself is an inflammatory agent, so they need to really cut down as much as sugar as possible. And that will be my advice. Again, I mentioned about the healthy advice with the low sort of fatty foods, and the fast food should be cut down. And children should have, as I mentioned, more maybe omega-3 fish oils and rich with vitamins. And maybe if the grain they're going to use, they should be whole grain. Grain should be used. So these sort of things are useful, but particularly the sugary content, chocolates and everything, because sugar itself is an inflammatory agent, and the GIT should be discouraged.
So just to kind of, I think, conclude that there are, as you said, there are few good points, the increase in family life and getting close to each other and supporting each other, from the community and family level. But of course, the problems with COVID and this pandemic, they are just kind of quite a lot and outweighing the good points. And there is a need of using the resources, which are going to be again imbalanced with the increase in, as we expect, a surge in referrals will come with increase in the problems and plus the delay in services.
Surge is going to last for years to come.
Yes, of course. And this is what we need to use the resources in the most effective way. And innovation is something, and the creativity is something which is on its way, with more research opportunities to see what is really being effective and how it can be made effective.
Social and economic crisis will cause the main crunch, because people are going to lose jobs, they're going to lose their houses.
It is multi-phased and it's multi-layered, of course.
Yeah, I think we just need to conclude now. We have just got 1 minute left. So thank you.
I hand it over to you, Sobia.
Thank you everybody for attending the webinar, for all your questions and all your comments, which has led to a very good discussion. Thank you so much, Dr. Asfa, for chairing the session today. And thank you so much, Dr. Ahmed, for such a riveting presentation and kind of, capturing so many problems and all the strategies that you have given us. We'll take a lot that we will apply in our own lives as well. So just before we stop this seminar, can I just say, please join us next week for the 4th webinar, which will happen at 6 p.m. on the 29th of July. And that would be, again, in the mental health series. And the topic is sleep during the COVID pandemic. So thank you so much again for joining us, and good evening.
Thank you. Shahid is saying we should stay on the panel.